Hello and welcome to DocTalks, the vodcast, a Doctors of BC production. I'd like to begin by respectfully acknowledging on the land which I am on. I am on the unceded traditional territories of the Coast Salish people, including the Musqueam, Squamish, and Tsleil-Waututh nations. I'm honored to be here as a settler and coming to all of you today in my role as President of Doctors of BC. I'm thrilled to introduce a panel of distinguished guests that are joining me today, André Picard, Dr. Julio Montaner, and Dr. Chelsea Elwood, who are joining me in a conversation around World HIV AIDS Day and the start of Canada's Indigenous AIDS Awareness Week. André Picard is the health columnist at the Globe and Mail and the author of 6 books, including The Gift of Death, Confronting Canada's Tainted Blood Tragedy. He has been covering the HIV/AIDS crisis since the early 1980s. Dr. Montaner is a Killam Professor in the Faculty of Medicine at UBC. He also holds the Endowed Chair in AIDS Research. He's Executive Director and Physician-in-Chief of the BC Centre for Excellence in HIV/AIDS and a past president of the International AIDS Society. From 2014 to 2017, he was the UN AIDS Special Advisor on HIV therapeutics. He played a key role in establishing the efficacy of highly active antiretroviral therapy, also known as HAART, and since then has established the role of treatment as prevention, using HAART to simultaneously decrease progression to AIDS and death, as well as HIV transmission. Welcome. Dr. Elwood is a clinical associate professor in the Department of Obstetrics and Gynecology at the University of British Columbia and the medical lead for the Oak Tree Clinic as well, as the Antimicrobial Stewardship Committee at BC Women's Hospital. Thank you all for joining me today. Let's start the discussion with our first question. So December 1st is World HIV/AIDS Day, and it's also the start of Indigenous AIDS Awareness Week in Canada. Can you comment on the meaning of this date for you? I'll start with you, André.
Well, for me, it brings back lots of memories because I've been at this for a long time. So I recall the early days when it was really hopeless. And today I think is a more hopeful, not a holiday, but a commemoration. That day commemorates a lot of what's happened, progress, the wish that we would make more progress. But this year in particular, it's kind of happening under the shadow of another pandemic, as we know, under COVID-19 for the 3rd year. So it's a reminder that we've kind of forgotten that bigger pandemic with tens of millions of people who have died, many more than COVID over a long period. And it's, I think, a reminder that we still have a lot to do.
Dr. Elwood.
Yeah, so I think from my perspective, it's a moment where you kind of pause and you look back at the whole epidemic overall. And we really think about sort of the women and the children that have been impacted by HIV and have not survived the HIV pandemic, in particular for the children that have been involved. And as a group, kind of, we sit down and we think about what are we going to do next? So how do we improve care? How do we do something different here? And we set out some very deliverable goals each year about what the next steps are in the pandemic.
Thank you. And Dr. Montaner?
Yeah, I think I should build on the themes that my colleagues brought up. This is a time for reflection and to remember, as André pointed out. But as Chelsea mentioned, it's also time to refine our targets and to ensure that we don't leave anybody behind. Unfortunately, we know what needs to be done, and we're falling short on implementing the strategies that should actually bring the pandemic to its knees.
André, you started your career as a student journalist covering HIV and AIDS in the 1980s. How do you think the healthcare conversation on this topic has changed since you started covering it?
Well, it's changed dramatically. At the beginning, it was new, it was scary, there was no treatments. It was a very political issue. So in student journalism, we were really interested in politics, in the social aspect of this. The raids on gay bathhouses, et cetera, were the norm back then. Lots of discrimination, lots of fear. So that's changed a lot, but we've almost come full circle. Had a lot of progress on drugs, et cetera. We, as Dr. Montaner said, we know everything that we need to do now, we're just not doing it. It's a very different situation, but it's almost come full circle in that it's become very political again. It's about, we see this new rise in discrimination based on race, based on gender, based on sexuality. And it's a reminder of, in 40 years, we've not come that far. We still have the same underlying prejudices, the underlying inequalities that have fueled this pandemic continue, and in many ways they're getting worse.
You raise really interesting points about prejudice and discrimination, especially the healthcare inequities that continue to exist in our current environment. And Dr. Montaner, over the past few years, we've seen HIV infections reach their lowest rate since the disease first hit BC. What is driving this, and what needs to be done?
This is a very important issue, and it's certainly very close to my heart. I spent the last several decades trying to develop the body of evidence that would inform how we can use the therapeutic tools that we have available, namely treatment as prevention, to bring this disease to a very solid control. Of course, it's not just about treatment. It's about treatment, care, support. It's about facilitating testing, decreasing discrimination and stigma so that people can actually access the services and the support that is needed for most at-risk populations to be appropriately cared for, whether it's condoms and lubricants, or whether it's injection paraphernalia, or consumption sites, supervised consumption sites, or safer drug supply. All of these subjects need to come together if we're going to deliver the programs that our patients need ultimately to benefit themselves so that they don't progress to AIDS and they don't die prematurely as a result, but also so that we can stop HIV transmission. If we're able to actually identify everybody that is infected in a region, if we're able to support them so that they access treatment and prevention, whether it's HAART or PrEP, pre-exposure prophylaxis that is, then we're going to be in a situation where the generation of people infected with HIV today will basically take that to their grave at an appropriate time due to other morbidities and age-related problems, etc. If we achieve that, we can see the end of the epidemic. And we're not actually deploying the tools because we just don't have this as a political priority.
So you brought up the political component again, and now I'm going to bring you back into the fold, André, before I come to you, Dr. Elwood. So André, you said that you believe health is primarily political and about policy. What do you mean by this, and how do you think it relates to this dialogue around HIV and AIDS specifically?
Well, it's political because all the decisions on what we do and don't do are driven by politics, by public policy, by money concerns, by economics. If you look at AIDS, I often make the comparison between AIDS and COVID, and they're very similar in that they both occurred at this intersection of racism, of sexism, and ageism. And this is what drives unhealthy results, right? It's all about our behaviors, how we treat people in their environment, the environment they live in. And that's true of AIDS, it's true of COVID, it's true of heart disease. This is the fundamental, the social determinants of our health are what matters. And we don't take that seriously enough on a political scale.
And we know that this year's theme for World's HIV and AIDS Day is around equity and tackling the inequalities around HIV/AIDS testing, treatment, and prevention. And how should we think about these inequalities in a Canadian context, and what can be done about them? Dr. Montaner, and then I have a specific question for Dr. Elwood.
Well, at the end of the day, what we are striving for is to have a world where people who are in need of the services that we actually have available, but they are not easily accessible, particularly to these populations or subpopulations that are harder to reach. As I said, we are striving to a situation where we can, the society can make a commitment to bring the services to the people, to bring those things together. The real failure, and what it breaks my heart, is that we have everything that we need to make this strategy work. And every time that something happens, we're very happy as a society to distract our attention and to say, no, sorry, this has to wait because we now had to do the COVID thing. Or no, we have to wait because we have the Mpox or the Zika virus, or you name it, the recession or the war. Any excuse is a good excuse to change the agenda. When it comes to an epidemic or a pandemic, better yet, there is no way to solve the problem if we don't go pedal to the metal all the way until the end. I often tell people there is no such a thing as a stable epidemic. Either you're winning or you're losing. And the problem with the HIV epidemic today is that in Canada, the incidence of HIV has been stable for the last 3 decades. And this is unacceptable. The province of British Columbia has seen a 90% decrease in the number of HIV infections since the peak of the epidemic in the 80s. The rest of the country, not so much. Today, we have among the lowest incidence rate in the country, approximately 2 per 100,000, which is half of the national average. Next door, Saskatchewan has a more than 10-fold greater HIV incidence. Manitoba, nearly 10-fold greater HIV incidence. Even Ontario and Quebec have approximately double the incidence that British Columbia has. Why? Because they have failed to fully implement the programs that we're advocating for. And unless we make the public aware of the situation, unless there is a public demand for this to happen, it is not going to happen.
So if you've got listeners today that are across the nation, across the country, what would be your advice to those people in those provinces or in those jurisdictions, if there was a political avenue, in order to encourage that change in the incidence? Because you said BC is doing such a wonderful job.
We need to demand accountability from our political leaders in every aspect of our life, but in this case, as it relates to HIV/AIDS, we cannot tolerate that people actually accept a stable rate of HIV infection across the country, or even worse, areas where such a high level of infection as is happening in the larger provinces in this country, because that's driving our healthcare into the tank. When we talk about healthcare sustainability, there is no better way to sustain our healthcare than to deploy these strategies optimally so that we can finish the problem as opposed to perpetuate it and make it even worse for all of us. I remind you, the strategy of treatment and prevention, with all of the results, is actually cost saving. So we're not even asking for a favor. What we're saying is do the right thing and we will all benefit. The patients, their families, we protect their children, we protect their wives, we protect their partners, we protect society at large. There is nothing wrong with that. And we should stop worrying about whether we like it or not. This is the right thing to do.
Oh, I love that it's the right thing to do. So why don't we do it? I have a question for you specifically, Dr. Elwood. Women, infants, and children often get missed in this conversation around HIV and AIDS. Why is this, and how can we improve on this?
So I kind of think, as you pointed out, André, this is like a political issue, right? And HIV exists within the fabric of society. And so you have the issues and the stigma and the challenges around HIV care. And then you're going to layer on top of it the gender issue. And this is an issue that's, coming forward in the last decade or so about the inequalities that women face. And then you layer on families on top of that. And so now you have a group of individuals who are struggling to access care on HIV care, but you throw in all the social determinants and you throw in that gender lens, and then they lose consistently across the board. Because not only are the people at the upper levels who are making those decisions missing the gender lens, there is a gender issue at those levels in terms of representation, but they're marginalized to begin with and can't advocate for themselves. So consistently, women, and women don't live in isolation, and children don't live in isolation. You could say that children don't live in poverty, women do, because families are so integrated together. When you don't actually address those meaningful way, they lose consistently. And then you throw sort of the EDI lens on top of things in terms of ethnicity and all that kind of stuff, and now you have a really marginalized group of individuals whose needs are not consistently met across all provinces across the country. And then there are significant intergenerational impacts of perinatal transmission and all those things that get missed and carried through. So I think that's where women and children lose, is because you are within that fabric of society, and we're just now starting to equalize things and have those conversations.
I'm so glad you raised these points, and you're absolutely right. These healthcare inequities, it's glaringly evident with gender inequities and the bias in medicine in general, but really in these specific populations that are really having some hardship. I'm going to ask both of you and Dr. Montaner if there's anything important for doctors specifically that may be listening today to know about HIV/AIDS, and it relates to patient care, especially for women and children and the vulnerable or hard to reach populations.
Yeah, I think it's really important to recognize that when you are providing care for individuals who are at risk of HIV, who have HIV, and you're providing care for those families, you have to treat them as a family. You can't separate them out. You can't treat them as individuals because they come as a package deal. And if you're going to ask a woman to take her antiretroviral medication every day, but she doesn't have daycare and she can't go to work and she's working 3 jobs, and you're not addressing all those social determinants, well, not only does that individual lose, but that family loses, that kid gets behind in school, and now you're creating those generational impacts of HIV care. So that's why when you're talking about families and you're talking about women and you're talking about children, you got to do it kind of together, and you can't do it in isolation. And what we see is within the healthcare system, really it's an individual patient system. So I see a person in front of me, I treat the person in front of me, but I don't talk about everything that brings that individual to that clinic at that moment in time. And I don't necessarily provide services that provide that wraparound care that families actually need to be able to be successful.
That's a really good point. Thinking about the whole family and the relativity of the health of the family and well-being and the social determinants of health. Such a clear, and especially when you frame it as such, but also a lens in which all of us as healthcare providers definitely need to be thinking that we're working within a system that is siloing healthcare consistently. But when we participate in our patients, we also see them as individuals. And I think the time is right to change that conversation. Dr. Montaner, any thoughts to add to this?
Well, I agree with everything that you heard so far, but I want to expand on that by saying that while the family unit is easy to understand in the context of a mother, a father, and their children, we're dealing with other less conventional units when it comes to MSM, when it comes to sexual workers, when it comes to First Nation individuals, when it comes to individuals who inject drugs, or even the ones that smoke drugs, who are also at risk for HIV infection as a result. And in that case, we need to think beyond the family to the group under which they are operating. Who are their partners? Who are the people they hang around with? Who are the people that basically are entering into contact and therefore are potentially at risk? Because they form a unit at the end of the day. And so we need to expand from the notion of family to the notion of, say, clusters of potential transmission, which is the angle that we're taking currently to hopefully identify the last sources of HIV new infections in our province.
So what you're also speaking is that not only community, but society as a whole. We need to think about health as a holistic perspective when we bring it into this. I'm going to move us on here, André. I've got a question for you. Last year you wrote about AIDS, how it almost feels like yesterday's news, given the COVID-19 pandemic. How do we bring the focus back onto this very important topic?
Well, I think it's a reminder that it's not over. So I think, for doctors in particular, they have to have the awareness. They can't make the mistake of some people in the general public and thinking, oh, this is done. All you have to do is take your drugs and you'll be fine. AIDS, HIV transmission is 100% preventable in babies. The idea of any child ever being infected again should be unconscionable. So doctors have to have that thought. They have that in mind. They have to embrace treatment as prevention. You can prevent, if you have a patient, you can prevent them from spreading it to others by reaching out to their partners. Again, you have to be aware of who's most at risk. So intravenous drug users, trans women, sex workers. Just be aware of who your patients are and bring up this conversation. It's so important because, as Dr. Montaner said, this is almost entirely preventable now. We've shown that in BC, and doctors have a really important role to play in continuing that and eliminating this threat.
Right. So where would you like to see the conversation on HIV and AIDS go from here?
I think we just have to incorporate it. It has to be part of our everyday conversation. We do these little blitzes. We do our World AIDS Day once a year, but it just has to be part of the conversation when we're talking about homelessness, when we're talking about the challenges of trans patients, of living in poverty. These are all issues that are tied intrinsically with AIDS. So we have to make it part of our everyday discussion, not something that we get excited about once every decade.
So a reminder to our listeners that making sure that it's top of mind and inclusive in your practice or your patient contact. I also want to ask you if you think, did we learn anything from how COVID was covered that should be applied to the HIV/AIDS context?
Oh, I think there's really important lessons from COVID for health more generally and for AIDS, HIV/AIDS specifically. And I think the big one is all the technology, all the drugs, all the vaccines in the world are not useful if you don't communicate well, if people don't accept them. So, we talk about this holy grail of the AIDS vaccine. I think COVID taught us that even if we magically had an AIDS vaccine tomorrow, it's not a given that people will take it, that there won't be prejudice, that there won't be misinformation. So I think it really taught us the importance of communicating well and really going beyond, connecting with people is so much more important than just having fancy technology. It has to be available. It has to be distributed equitably. We saw that with COVID. That's something, a long-standing issue in AIDS. I think we do a lot better with the equitable distribution of AIDS drugs, but it's still not perfect.
Thank you for that. I think you touch on the elements of trust and transparency and conversation and dialogue, which is really important for us to foster with our relationships with our patients, but in the general public, in what you do by communicating so well and effectively on a national landscape.
And I think we have to remember the communities that are hardest hit, that are most at risk, are the ones who have the least trust, and for good reason. So that is a double challenge.
That's a really good point. Dr. Montaner, I'm going to ask you to explain for our listeners what the UN 95-95-95 target is and how can we reach this in Canada?
So back in the day when we started the treatment of prevention campaigns, Michelle Sidibe was executive director of the joint program of the United Nations, the AIDS program for the United Nations. And I happened to have a good relationship with him, and we were able to work together very well. And so in 2010, he embraced the notion of treatment of prevention. Meaning, let's find out the HIV status of everybody as much as possible. Those that are HIV positive, let's offer them treatment in a supportive way, free drugs, etc., with appropriate monitoring, to render their virus undetectable, because in doing so, the immunity recovers, they don't get sick, they don't develop AIDS, they don't die prematurely, and in addition, they become non-infectious. In other words, they cannot transmit the virus. At the time, this was viewed as controversial. It took a few years, but eventually we managed to impose that in the scientific community with clinical research, trials, and the like. However, I remember quite vividly Michelle coming back to me and saying, look, Julio, we have a problem. I am, say, in South Africa, and I ride in the elevator down with Montesaleri, who at the time was the Minister of Health in South Africa, and I tell him, look, you should be doing what Julio is doing in British Columbia to control the epidemic in South Africa. And the response would be, oh yeah, we're doing exactly the same. We have testing, we have treatment, we have, you name it. So it became a real problem for us to try to communicate treatment and prevention and close the loop so people would not be sort of squeezing out of the cage, if you want to put it that way. And so what we decided is that we needed to create very strict metrics that would dictate the trajectory that the effort should take over a period of time in order to drive the epidemic to what we call the end of AIDS as a pandemic concern. So end AIDS as a pandemic, meaning that if you reduce the burden of disease by at least 90%, we would be transforming the pandemic into an endemic condition. And of course, further effort will be needed to bring us to the next level. But if in my lifetime I manage to reduce the burden of disease in 90%, then I'll be happy to say, well, they will try to push that envelope and see how far we can go. So what we did is we used the BC data to create a model of what would have to happen, epidemiologically speaking, to drive the epidemic down to the 90% decrease in disease burden by 2030. And what we found was that by 2020, we needed to be at 90-90-90, meaning 90% of individuals diagnosed, at least 90% of them on antiretroviral therapy, and at least 90% of them virologically suppressed. And subsequently, by 2025, the target should move to 95-95-95, which basically says that by 2030, we would like the target to become 100-100-100, if we can ever do that. But that was sort of the sense. We launched the 90-90-90 by 2020 in 2015 at the Vancouver conference that we had the pleasure to organize here. And that was basically the closing of an era of work. Saying, yes, we have all of the evidence. If we do this, we'll drive the epidemic into sort of exhaustion. I was gratified, very gratified, when Antonio Gutierrez in 2015 recommended, even though not all of the countries have been able to get even close to the 90-90-90 target, to move on to the 95-95-95 target at the United Nations level, recognizing that we could not go backwards or delay the strategy any further. And so the 95-95-95, meaning 95% of people diagnosed, 95% of the diagnosed people on treatment, and 95% of of those on treatment virologically suppressed by 2025 is currently the new goal of the United Nations that has been endorsed by every country that is signatory to the UN, including Canada. And yet we're not doing it. And this is why I'm so frustrated. We need my colleagues around BC and in the rest of the country and the world for that matter to raise a voice and say, we want to do this because it's the right thing to do.
Thank you for that. Again, for our listeners today, if you haven't heard it now, the compelling reasons to change. We are so close, that 2025 target, that it's just going to take us to really pay attention to the diagnosis, to suppression, and to really move in that direction. But it takes us as a collective, as we know that we've been navigating through the pandemic, it takes all of us. And I think hopefully for our listeners today, they'll be compelled to make changes and really push it to the eradication. And if we can do it, we know it's the right thing to do for our society, our patients, but the people that look to us for guidance. I'm going to ask you some questions, Dr. Elwood, regarding HIV and women, and really in the context of how you work with these populations. But what do you think the current burden of HIV is in women?
I mean, we know that proportionally speaking, there is fewer individuals who are women and children in the province of British Columbia who are impacted by HIV, right? But globally, we know that 52% of HIV diagnoses are in women. Women and children is a little bit harder to sort out globally because of the testing challenges particularly. And also, like we talk about a 95% treatment goal, well, what is the pediatric lens on that? And how are you getting antiretrovirals to little kids who have HIV? There's a whole section of that population that gets missed in those 95 conversations because they're pediatric, and it's a very different story. But I think that what we are really trying to recognize is that concept of families and holistic care and how women are impacted by HIV. We know that like 60% of women will experience violence when disclosure occurs. That's a really significant number. We know that like more than 60% of women with HIV have food insecurity. And so that food insecurity that the patient in front of you has also impacts their kids as well. And so by trying to tackle this as a package deal and providing that wraparound care, we're trying to meet all of their needs in one place, and we're trying to support them to be able to function within their community, take care of their kids and be able to be productive, but also have their HIV care done appropriately.
And what about youth and adolescents?
Yeah, so now there is a population that really doesn't get talked about. And I think it's a population that comes to us in two different ways. So there are the group of individuals who were perinatally infected from early, and are now aging appropriately and are now becoming teenagers and have been infected with HIV basically since birth. And then there certainly is a significant at-risk group of youth who acquire HIV through substance use disorders and heterosexual transmission, and they come into their HIV in their teenage years. The expertise to manage those individuals, to support those individuals is very limited. There are lots of physicians, a good chunk of them work at Oak Tree Clinic to provide that care, but their population needs are very unique. You can imagine the stigma of being an adult with HIV or being anyone with HIV, but layer that on to being a teenager with HIV and all the chaos that goes on. And what we do see, for example, is those individuals who are perinatally infected, they do really well when their mom's in charge of giving their medication. But then they hit their teenage years, and what teenager actually wants to take their medications when they're 16? And what teenager wants to tell their girlfriend or boyfriend or partner that they have HIV? Those are really difficult conversations, really challenging. And then we see them come through, and they come with some very difficult resistance patterns because of the compliance issues with medications. We know that we look at data in terms of overall outcomes. The perinatally infected individuals don't do as well as the adult diagnosed individuals. And then we were talking about aging into care. Well, pediatric aging into adult care is an issue across the board. Doesn't matter what your diagnosis is, whether it's HIV, heart disease, kidney disease, doesn't matter. There is a huge care gap that occurs if you don't have mechanisms in place to support those individuals that go from infancy all the way through adult care. And we actually don't know yet, because the pandemic hasn't been around that long, to know what living with HIV from birth all the way to age 60 or 70 is going to look like. So those care models and all that information and research needs to happen and hasn't happened yet. So we really need to be acutely aware of those individuals, and they will be a larger number of our population who are diagnosed, and we'll need to meet them as well.
I think you raised really good, questions even that come to mind about that care gap. And I know someone that knows about the care gap very well here. We have André, who this is one of your passions. But how do you think that the care gaps really affect HIV families or the HIV community?
Well, as was said, this is an issue across the board, but it's particularly a problem when you have more complex illnesses like HIV as lifelong. We know the medications have impacts, results in heart conditions. So it's the complexity that makes the care gap even more yawning, if you will.
And I'm going to ask everyone individually about this question, but I want to talk about stigma. I know this is definitely in front of mind for many of us that have looked after patients with HIV or AIDS. But really, what has been your experience? I'll start with you, André, and then go through the panel.
I think the issue of stigma has changed over time. Very early on, there was really dramatic, the stigma, the targeting, the homophobia, etc. Now, I think with gay men, there's much less stigma, but the stigma has gone into other communities, and it doesn't exist strictly because of HIV. Intravenous drug users are stigmatized for a whole number of reasons. Trans women who are very high risk are stigmatized for other reasons other than HIV. So it just adds, it's like a piling on to these stigmas that already exist in society.
Right. And Dr. Montaner?
Yeah, of course I agree with all of that, and I think that despite the fact that we have made progress, we are nowhere free of stigma in any of the aspects of our work. We face challenges that administrators don't like the work that we do. We face challenges that our colleagues don't like the work that we do. They don't like our patients, and our patients are not necessarily welcome in the traditional medicine wards. And I could go on forever and ever and ever. But I'd like to turn that around and sort of add a positive note to the stigma issue. And this is an anecdote. A good friend of mine, Nikos Dedes, who is an activist from Greece. Nikos came to, and he has said this publicly, so I'm happy to repeat it. So Nikos came to Vancouver in 1996 when we launched for the first time highly active antiretroviral therapy. And I had the privilege of presenting the data on the particular regimen, which was triple therapy with a non-nucleoside reverse transcriptase inhibitor, which is all history, all very nice and doesn't matter. But it was great. And I was very happy with that because it made a huge difference. The protease inhibitors came at the same time, and life changed for people with HIV dramatically thereafter. So that was good. In 2006, we basically came up with the notion that treatment could prevent transmission in addition to morbidity and mortality. We created the treatment prevention moniker for it. And in 2006, I presented this in Toronto, at the Toronto International Conference. It was sort of the big breakthrough of the day. And that's when I met Nikos Dedes. I hadn't met him before. So he called me out and he says, Dr. Montaner, I wanted to meet you. And I said, yeah, well, nice to meet you. I know of your work. And he said, well, I wanted to thank you because the work that you presented in Vancouver was inspirational for me. I actually started treatment right away, and it saved my life. It's been great. I said, well, thank you very much. I'm really pleased. And, it was the effort of a collective of people, so blah, blah, blah. I said, no, but that's not what I wanted to talk about. I wanted to actually share with you the fact that when you presented treatment as prevention, I experienced a sensation that I never expected. I felt the stigma lifting from me, the self-imposed stigma that I live with all this time, because for the first time, I felt no longer I was dirty or a risk to my partner. And if I can leave people with one positive message, we need to do this because it's right, but it can have a profound impact on the life of the people that we're trying to help. We will see no more children infected with HIV if we actually protect the mother and the father and whoever else is involved in their care. We could end the pediatric epidemic overnight if we do this right. We could actually give people back a normal life, make them feel that they are normal members of society, despite the fact that they're taking a treatment every day like anybody else with diabetes or hypertension or whatever. So we can do that, and we're not doing it because we don't want it, because it's not a political priority. Why? Because there are politicians and there are people in very influential positions who actually don't care about these people. And that actually is costing us more, is making us suffer as a society, and it's not acceptable.
Wow, what profound statement. The fact that he felt the stigma leave him. And if that doesn't resonate with our listeners today, reminding ourselves that we're all humans on a journey. And now the pleas for humanity is that we have this opportunity. We in medicine, we help aspects of healthcare. We participate in our patients' lives and their journeys. And all of you, which you've been sharing throughout today's conversation, has been, again, that comes back to the push on society and our political leaders. I hope that I've used somewhat of my little political platform here to engage listeners with the intention of changing conversations. And I think with the HIV/AIDS, for me in particular, I've been so interested, and I know, André, when we've spoken, that you spoke of the times and where it started here in Vancouver. And I've also met many of the colleagues that were the ones with the stigma when so many of our patients were not getting the care and stepped up. There are many family doctors here, as well as the specialists and consultants that provided that level of care and really cared about the human aspect of healthcare. And I think, again, for me, it brings us back to that point. If health is the most vital and important asset that we need to protect, then why are we not there? Why are we not knocking down the doors to make sure that this is the way we move? And we also know, and from the learnings of the pandemic itself, the world came together, we made a vaccine, and you're right, and it had some uptake. We were lucky, we were in one of the jurisdictions that favored quite well. But if we could just pull together, and you made a compelling argument there for not having any pediatric cases. And I know, Dr. Elwood, with the work that you do in your clinic, and I want our listeners to understand a little bit about what Oak Tree Clinic is about, and why it came about and how it evolved. And if you can share that with them, because I really do want people to know that there is a different way of doing collaborative care.
Yeah, absolutely. And I will just actually make one comment about stigma, if that's okay. So I think there are a couple of things that are challenging, particularly in women and children, but just in general. We know historically, from the dawn of time, infectious diseases in general create a ton of stigma. And we actually saw that during the pandemic. I don't know, you guys must have experienced this, where it's like, oh, where'd you get your COVID from? Who got COVID? Did you get COVID? That kind of thing. So there is this deep-seated fear, sort of historically, around infectious diseases in general. And so HIV, being an infectious disease, carries that type of stigma, as well as sort of modes of acquisition and all the social determinants that comes with that. So it's a big beast to take on. And I would say, yeah, we're making some progress around stigma, but I can tell you we're not there. So for us particularly, here's a classic example for us is breastfeeding. So we recommend against breastfeeding in North America because of the risk of perinatal transmission, regardless of whether you're on antiretroviral therapy. But we spend a significant amount in our time in our clinic talking to families about how to not breastfeed and not disclose your HIV status. Because in lots of communities, if you don't breastfeed, it's because you have HIV. And if the fact that people fear that disclosure still means the stigma is not gone, because they're afraid that someone's going to find out that they have HIV because they're not breastfeeding. And so the fact that there's even that continued connection means that the stigma is still present. It's still very real. Again, women are disproportionately affected by violence when they disclose. They have higher rates of criminalization for HIV, all those things. So it's not quite gone, and we still have to continue to work at that. And so, as I say, at Oak Tree, we take a multidisciplinary approach to this because for us, the antiretroviral therapy is really important. It is. It absolutely is. But it's all the other parts of care that are really important. It's the dietitian. It's the, providing culturally safe, trauma-informed care. We have psychiatry. We have social workers. We have outreach. We work a lot with our Indigenous population. We do walkthroughs. We make sure we're trying to provide all those other parts of things, pharmacy, the whole package deal, because it is everything else that dictates whether you can provide good HIV care or not. Handing someone an antiretroviral and saying, good luck, take your medication, doesn't really work. meeting them where they're at, supporting them through their trauma, because a lot of these women and children have experienced significant trauma. We have a large number of international adoptees that come through with all the trauma of those kind of things, makes the HIV care successful. And we work in a very collaborative way with physicians, nurse practitioners, the whole package deal, because it came organically from a need. So in the 90s, when the HIV epidemic was largely in the MSM population, there was a number of women who had HIV, and then they were getting pregnant, and then every baby was getting HIV, and it needed to come from a place where that came. And it's organically grown. Oaktree's been around for 28 years now, doing that type of care. The irony is that a lot of people come and they say, they're reaching out, they're writing CIHR grants, they're doing all those kind of things to say, what's the best model of care? And they land on the model of care that's already there and that we have been doing for a long period of time. It doesn't mean we centralize care, so not everybody's got to come to Vancouver, because that makes no sense. We really support care in communities, we deliver in communities, we try and support practitioners in communities to take care of the families in their communities, because that's where their social supports are. And so that's the way our kind of care has come about at BC Women's Hospital, because we think it's the best way to provide care for these individuals.
That's really great. André, do you have anything to add on the collaborative care models? I know that you've had some interest in that.
Well, I think we've been talking about this for many years. We have all these examples of how it works for specific illnesses. It works more generally. It's really the future of care, and I just never understand why we're not just going there at full speed. Medicine is so complex today. You can't just have a little family doc hanging up the shingle on Main Street anymore. That's quaint, makes for a good Marcus Welby TV series, but that's not reality anymore. We need this cooperation. We need to exchange ideas, to have people who can learn to keep up with what's going on. And it's, I think, was said very eloquently about Oaktree. It's not just about handing somebody a pill. It's everything else supporting their lives so that that pill will work. And that's what medicine should be about. It's just the treatment is just the tip of the iceberg.
That's a really good point. And in your eyes, you see a national and a global lens with healthcare, and you do definitely create an imprint, and the world kind of listens to what you communicate, especially so effectively with your words. And to put you on the spot here, if we had a call to action for our political leaders and saying that we were going to frame collaborative care as the new way forward, do you think that they would be able to do this?
Well, I think anything's possible. It's I think I say to politicians, the best thing they could do is get out of the way. Just take these models that work, scale them up. That's what we have to do. So I think, we have this larger discussion about health reform these days, and I think it all begins with primary care. You can't have a good health system if you don't have a solid foundation. So then it becomes, how do you want to deliver primary care? And I think, again, it's not the single doc with the shingle out on Main Street. It's now interdisciplinary clinics with a mixture of dietitians and psychiatrists, whatever depends what the community needs. So have that mixture, and that's how we're going to provide good care. And it's not more expensive, it's just different, and it's all doable. And again, we have many models of it working. Let's take our successes, scale them up. That's how reform has to go.
That's a really good point and an interesting point. And I think what you said about scalability is absolutely the way we need to move forward, but also that sense of community, what the community needs, and going to where the community is. And Dr. Elwood, you touched on that as well, is that you're providing care, highly sensitive care, but highly specialized care to families all across the province. And Dr. Montaner.
All of this resonates very much with us, because the key to the success of the program in British Columbia has been to decentralize care and make it the domain of the general practitioner, so that we can bring care closer to home and support them with a specialist. But at the end of the day, we realized we were very few with a specialty interest in HIV, and yet we could function much better if we could do this as a larger team. In fact, it was the only way to do it. We have more recently opened a facility in downtown East Side. We now completed the first phase of enrollment. We have 1,500 people enrolled already. We're going for double that number. These are all people who were not engaged with care, the majority of whom are homeless, very much in the sort of Powell and Princess area, which is the heart of the epidemic, the IVDU epidemic. And because we are using the same model of care, we're able to combine supervised consumption with safer drug supply, with primary care, with a whole bunch of other services, including the non-traditional medical services, to support the needs of the people that are coming through the door. And as a result of that, we currently have 80% retention in a population that characteristically most often doesn't reach 20% retention. And so we're basically turning the system upside down to be able to show that if we have culturally appropriate care that is sufficiently low threshold and offer the services that people actually want and need, then you can have success.
That's, again, what another fine example. You both have spoken of two models of care right here in our backyard in Vancouver. And the ability for us to be able to take that and implement would make waves so profoundly within our community and our society, especially for healthcare. And hopefully we've got some politicians listening in on our vodcast as well that could make those changes, because I think you speak of such substantive changes, but really the 80% retention with people that, and again, we spoke about stigma a little earlier. People assume that people don't want care because of either where they live and the ability to deliver culturally appropriate care. And that again resonates with me, because I think that's the direction we need to move in within healthcare. What resources are currently available for the physicians or doctors or healthcare leaders that may be listening to this vodcast? Or what kind of education or training do you think they need around HIV and AIDS?
In British Columbia, we're very fortunate that the BC Centre for Excellence in HIV/AIDS has a cadre of services available. We work very closely with the Oak Tree Clinic, of course, and a number of colleagues at UBC, and SFU for that matter. And together we have a variety of programs, from regular updates to publications to everything that they need to be supported. The guidelines in the province are very detailed. They offer guidance for primary care practitioners to get involved. So we have all of the tools and the elements ready for any practitioner that wants to get involved. And we're more than happy to take calls from anybody to help them to move along the continuum of from testing to care to support, everything that needs to be done.
And Dr. Elwood for Oak Tree Clinic.
Yeah, so I mean, our lens is a very sort of women and children focused lens. We have, guidelines, and we have our order sets, which are our provincial order set for labor and delivery units and perinatal transmission. We sort of track and manage all the perinatal delivery kits that are on every delivery unit in the province, basically. And so we do all that kind of work. A tradition at BC Women's Hospitals, I will be giving grand rounds on World AIDS Day on Thursday. That's something we do from an education perspective. And we actually run a number of parallel kind of education sessions to the CFE, which are really focused on women's health issues and children's health issues. So we talk about sort of menopause and those type of things. I think one of the other things is we have a huge number of trainees who come through our program from all disciplines. We have pharmacy trainees, we have nurse practitioners we train, we have our sort of fellows who come through, but we also train all of our OBGYNs come through Oak Tree and spend an entire month just doing HIV care. And so we're sending out into the community a group of trained professionals who are armed with all the information they need to provide care for women and children in the communities, and they know that there is a central resource of support. We provide a voluntary call service, sort of Monday, Friday, pick up the phone, call me 5 days a week, and we'll answer questions for you. So we're really there to support and happy to educate. One of the other things we really focus on too is nursing, training, and learning. So we will go into communities and we will provide support to train the nursing staff on a delivery unit on how to do care for an individual living with HIV during that. We've done that multiple times so that women don't have to leave to come down and have a baby. Train the pediatrics teams, train the pediatricians to be able to support that care in communities, and we're very open to all of that kind of collaborative work.
Thank you for that. Now, one of the final questions, we may get into a little bit more. What's the one thing that gives you hope around World HIV and AIDS Day?
Well, I think what gives me hope is a place like BC, where we've showed that really we can end this pandemic. If it's down 90%, and as Dr. Montaner said, we're not doing quite as much as we could. we're very close. So why don't we have this model across Canada? That's unthinkable, that's incomprehensible. But then why not the broader world? This is all doable. 40 years ago when AIDS came along, it was like a catastrophe. This was going to be the end of the world, all these. And we've made progress, steady progress, but we have to keep it going, and we just have to implement what we know. That's the frustration, is all these areas in the world where it's so easy to do something and we're just not doing it. We're wasting money, we're wasting lives by just being, not doing as much as we could.
Yeah, and I think for us, what really sort of gives me hope, in particular this year and probably the coming years, is the fabric of society is changing around the conversation around gender and equity. And because the world is changing around the conversation around gender equity and the unacceptability of those differences, it makes the conversation in HIV care just a little bit easier, because it is in the same breath that you can say, have the HIV care conversation, but it's no longer acceptable for there to be differences between care for men and women, basically. And that's because the world is changing and it's becoming a standard part of language expectation that you cannot separate those two things. You must acknowledge them, and you have to actually work at creating equity in those situations. So for me in particular, I think that this is a particularly hopeful time for women and children with HIV because the world is changing around that conversation.
Thank you. And Dr. Montaner?
When I reflect about the work that we've done over the years, I had to say that my gratitude goes to the province of British Columbia for the incredible support that we have had from the public and the policymakers, all the way to the premiers. Every single one of them has actually rallied behind us, no matter the colors, no matter the stripes. I wish I could say the same thing about the federal government. It's a sad situation out there when it comes to some of the federal key players. Perhaps the worst years of my life were under the Stephen Harper administration, where we had a very open dispute about what the right thing to do was in the context of HIV. I'm very worried about Pierre Poilievre's latest video, where he's actually talking about something that doesn't understand very well regarding the how to fight the current epidemic of fentanyl overdose, death, etc. So yes, there is hope, and we have been able to show that we can work with every segment of society to move these programs further. But it worries me that BC has been a bit of an island, and that the rest of the country has found it very difficult to move along. And I worry that there are political ideologies that are interfering with our ability to develop the programs and deliver the programs that we need to deliver across the country. So I hate to get so specific about the political issues, and I'm not trying to make a partisan statement, but we need to be sure that whoever is going to take the reins as we go forward understands that there are some things that are non-negotiable, and this is one of them. We need to deliver on the province of treatment and prevention. This is a made in Canada strategy that has now taken over the world, and I find it offensive that there are some at the federal policy level that are arguing whether or not this is a good idea.
Wow, that's very powerful. And I think what it brings me to in the reflection point is definitely that when people say healthcare is not political, you have just demonstrated and spoke so eloquently around the fringes of healthcare have always been political. And my hope, and I'm going to come back to all of you for a 30-second elevator pitch to what would you like to say to the political leaders? Because for me, when I reflect throughout healthcare and I see all the disparities and inequities and the effects on different populations, and the way that we're moving is, again, allowing people to have the capacity to even define what gets resources and what doesn't. If we can collectively, as a nation, understand and embrace that healthcare is a vital asset for everybody living in this country and who the country supports, irrespective of partisan opinion. So maybe a non-partisan approach to healthcare and rallying behind those needs. And I don't know if the future will allow for that, but that's my hope when I think about HIV, AIDS care, or any other disease entity where there is this political opinion that rejects the healthcare opinion or when it's the right thing to do. And so I think it brings it back to this moral conversation and an ethical debate of who is to determine that. And if policymakers are determining if health is popular in some jurisdictions and not others, then that's one of the gross and glaring inequities. So I'm going to come back to you guys for your elevator pitch. If you had a political leader listening today, what would be one thing that you could change that you would ask for?
I always tell advocates, when you want to influence someone, you speak the language that matters to them. The language of politics is money. So I would make an economic argument. Imagine a world without HIV/AIDS, how much money we would save, how much suffering we would prevent, all the other things we could do. And that applies more broadly to healthcare. Follow the science, and you're going to get good results, and there's going to be a good return on investment. And politicians don't do enough of that. There's too much partisanship, there's too much game playing, and just follow the science and we'll all benefit.
Thank you. Dr. Elwood?
Yeah, and I would agree. You got to make an economic argument when you're talking with politics. But I think the economic argument is actually quite simple in our case, which is gender equity and empowering women is a very good economic idea. There's lots of models out there that show that if you equitably create that platform for those individuals, particularly for women, you will win. And when you don't, you lose. And so that's a choice that you make by bringing that equity back up. And if you don't, well, that's your loss.
So of course, I support precisely what my colleagues have referred to, but I always like to give it a little bit of different spin. Back in the day, I was a young physician, and I was basically advocating for more research and more work and more drugs, and doing my, what I was trained to do. Eventually, we came up with a few breakthroughs. Doesn't matter what, because there have been many over the years. And over time, I started to realize that that we knew too much and we were implementing too little. And that started to worry me. And that's when I basically agreed to step up and run for president of the International AIDS Society, because I made a conscientious decision that I needed to articulate the message for our policymakers in a way that they could not hide from it. Yes, using the economic argument, yes, but I had to do it myself, because waiting for third parties to understand the message so that they could translate it, even though there are some that are very good at, like André is, but there are very few of Andres around the world. So we needed to step up to the plate and start advocating directly with the policymakers. And so something funny happened in 2006 when I made a presentation for treatment prevention, and then I went to a meeting and I had an exchange publicly with Tony Clement, who was the Minister of Health at the time. And so he was actually not happy with me, and from a distance said, well, everybody knows that we disagree with Dr. Montaner in everything he says. He's no longer a scientist, he's an advocate. And I said, yes, because you need an advocate to actually change your mind. And that's the only one that can do it, is somebody that understands all of this. So I guess when you ask the question about what to do next, instead of taking the position that we need to make the case to the politicians, I would like to make the case to our colleagues and say, hey, buddy, get up and just start helping us by advocating for what you know that works. Because the problem is that too many physicians know very well what needs to be done, and they are too busy looking after their practice, which I respect. But unfortunately, if they don't share the courage of those of us that are trying to change the medical system for the better, we cannot do it alone. So today, I think is a proper day to say, hey, come, join us. We together can provide a stronger voice to motivate our physicians, to strengthen our healthcare system, to expand treatment of prevention, not only to HIV, but hepatitis, tuberculosis, sexually transmitted diseases, and many other conditions that are totally amenable for this type of approach, which will render a tremendous benefit for society and for the economy.
Wow, that's a really great closing. I think that if you haven't heard that call to action and to get out of your seat and to go do something, I know we're tired. I know that these last few years with all of the colleagues across the province and around the world, healthcare leaders are very tired and they've had a sense of moral distress. But I'm going to wholeheartedly agree with you. because I really do think that there is a place, and for many years we were told there's no lane for doctors, stick to your doctoring. And I really want to speak against that, because every day that you see someone in your clinic or in the hospital or wherever you are deeming your patient care, there is an opportunity and there's a skill set. And I believe that we do it so often one-to-one, but that is the same thing that I would love for our listeners and our leaders to really be inspired by that hope and that trajectory, to lift our voices together, because I really do believe in the doctors of BC. I believe in the doctors and the leaders nationally as well. I feel like we've had, we time and time again, the world around you, it demands a lot of you, and sometimes it wears you down. But the same things that wear you down, they also have, I always say there's a 20% inertia quotient, and if it's activated in each individual, what we could do together could be tremendous. If we demanded that this is the way we're going to do things, and the status quo is unacceptable, and the way that we move forward is to revolutionize healthcare, and that's from cross disciplines. And you know that with many infectious disease states, or the approach to mental health or substance use, but really thinking of collaborative care approaches and teamwork. We know we have the answers. And right now, our patients trust us. They come to us for those answers, for their longevity and for the trajectory of their lifespan. Why should we not be influencing the system that makes the decisions that ultimately grants their life? So I just want to say a warm thank you to all of you for participating in today's vodcast and really accepting this journey. And I'm really hoping that all our listeners today really got a sense of hope and optimism, but really these leaders that have tirelessly advocated for us and compelled us to do the same. So wherever you are and listening, I hope this vodcast today inspires you and to really move a little differently this World HIV and AIDS Day. Thank you.